And I can promise you this, that the content of this is going to cover, because this is a it's a topic which is very heavily reliant on the entrance exams that we usually encounter, the foreign medical graduate entrances, or the FMG, or the NEET PG, or the INICT as we call it. This is one of the most important topics of that examination, and I've tried to compile almost everything. Trust me, so almost 90 to 95% of the content is entirely covered in the 20 slides that I've tried making. I'll only tell you to keep following this with me quickly. You can have a rough sheet of paper where you can make your own notes, but keep this PDF with you. Gagna, please make sure that this PDF reaches out to them. And I'll tell you, whatever you get extra when if you're preparing, as and when you're preparing for the medical entrance examinations, whatever extra you get, just add into this. And this is a compact set of notes that you have, so that should help you. And I will be beginning. I'll be sharing my screen. And I request, there's only one request that I have. I want you all to be involved, number one. Number two is it's a request from me to please keep your microphones off. I do not want any sound to interrupt the flow of this class. And I will try taking you through a wonderful journey. And in the end, we'll take up doubts in the end of the class. So we can join together, and let's hope we can make this eventful. I just want a thumbs up if my audio and my screen uh, are on the perfect note. I just need Kagna, can you just ensure me that
Yes, your
my
screen, it's not full screen now. Your voice
no,
is crystal clear.
yeah, is my screen full screen right now?
Yes, it's full screen.
Perfect.
Sure.
Perfect. So let's begin this. I'll just give me a moment. Yeah. So, as I start off this topic, I'll start off exactly in separate segments of toxins. I'll first begin with corrosives, and in corrosives, we can divide it into acids versus alkalis. The basic points, whatever is written, every word in this slide is very important. It's an exam question, has been asked at some point of time, or can be a potential question. So when I talk of acids, they mainly destroy the tissues via coagulative necrosis, except hydrofluoric acid, which is a past year question in itself. Hydrofluoric acid is the only acid which can cause both coagulative as well as liquefactive necrosis. Alkali, on the other hand, will cause liquefactive necrosis. Because there is a lot of coagulative necrosis that is happening, there's a lot of dead tissue which is being formed. So eschar formation is very common in acid injuries, and alkalis are not having an eschar formation. The lateral spread is restricted in cases of acids because it usually follows a more linear pattern of injury, a more superficial and a linear pattern of injury, which is why the injuries due to acids are less severe. This is a question which is often asked, that there's a patient who has ingested sulfuric acid, say, for example, sulfuric acid, that is H2SO4 ingestion, versus an NaOH, there's a caustic soda ingestion, which is supposed to cause more deeper injury. So the answer is always an alkali, which is unlike the belief we always think that H2SO4 is a very strong acid, maybe that is going to cause a severe injury. But the truth is, whenever there is an acid-based injury, it is usually spread to the superficial layers of the esophagus. So whatever injury will happen to the esophagus and stomach will be on a very superficial level. It will not involve the deeper layers, and hence there's less severe injury with acids compared to alkalis, because alkalis have number one, they have a very faster mode of spread. They can spread to the deeper layers, and naturally they can cause more amount of injury. That is why it's also a question which is asked, the risk of perforation is more with which form of injury, acids or alkali? The answer is again an alkali. Alkalis have a higher risk of penetration, a higher risk of faster spread, a higher risk of severe injury, poor prognosis, and perforation. Mucosal involvement, as I said, in acids, it's more the stomach which is more involved than the esophagus, while the alkali, because it penetrates deeper, so it will usually spread to the esophagus more than the gastric tissues. So these are independent questions which have been asked. Among acids, we usually have two forms of acids. One is the inorganic acids, one is the organic acids. When I talk of inorganic acids, they are mainly the sulfuric acids, the nitric acids, hydrochloric and hydrofluoric acids, and they cause injury via local effects. That is, the breaching of the mucosa, the formation of coagulative necrosis, and the eschar. Whereas the organic acids, for example, the carbolic acid, the oxalic acid, formic acid, acetic acid, all of them have both local as well as systemic effects. Why? Because organic acids will not just cause local tissue injury, but it will also spread via bloodstream and reach to other organs, thereby leading to the defects which will come in the systemic tissues due to their rapid absorption. Whereas if I come to alkali-based injuries, as I said, mainly it's caustic soda or sodium carbonate, potassium carbonate, ammonia. All of these are the ones which will have a more poor prognosis compared to an acid injury. Coming to acids, I've quickly just tried noting down the basic points about every acid. H2SO4, it's also called the oil of vitriol, and in the criminal sections that we have in India, vitriolage is basically what you mean when you say throwing acids on someone. I mean, there's a movie which was created in honor of this lady called Chapak, and that is exactly the crime that was done to her is basically called vitriolage. So that's something which you can remember. H2SO4 has hygroscopic property. The postmortem findings of H2SO4 have often been asked. You just need to remember H2SO4 makes everything black except the teeth. So the teeth remain chalky white, everything else becomes black. When I come to HNO3, nitric acid is known for the yellowish staining. Then the yellowish staining is due to xanthoprotic reaction, which leads to the formation of picric acid. I've only written things which are relevant for the exams. As I said, this is very compact. You can use this for building on through further questions and past year questions. So as I said, HNO3 will cause yellowish staining of the teeth, the mucosa, due to the formation of picric acid. When it comes to phenol, so when I was talking of H2SO4 and HNO3, they are basically the inorganic acids. When I come to phenol, phenol is also called carbolic acid, and the metabolites of phenol has been previously asked. One is pyrocatechol, the other is hydroquinone. And because of these metabolites, as I said, these acids will not just have local tissue effects, but will also have systemic effects due to absorption. So you can clearly see that these metabolites are what are traveling in the bloodstream and they are going to the different systemic organs. They can cause CNS depression, convulsions, meiosis or constricted pupil, cardiovascular shock, or often a PCT damage. PCT damage is something which is which is not found in most poisons. It's a rare finding. So whichever poison is showing PCT necrosis or PCT findings, I'll tell you to mark them and keep them in mind. Because it's also called carbolic acid, when it gets excreted via the kidneys, it leads to an olive green urine on standing, which is also called carboluria. Acute features of phenol toxicity include carbolism. These are the features that I've already talked of, which is CNS depression, convulsions, meiosis, shock. Whereas in chronic, we find phenolic marasmus. And when I talk of marasmus, I'll take you up in the later segments where I'll talk of how marasmus is, and then we can easily relate them to phenolic marasmus. A very important finding that is found in the cornea, the pinna, the ligaments, is something where pyrocatechol and hydroquinone will accumulate, leading to a feature called ochronosis. Ochronosis is the blackish discoloration of these segments that I talked of: the pinna, the cornea, the skin, the ligaments. And one more thing, phenol delays putrefaction. So I always remember it as P delays P. So phenol delays putrefaction is a point that has been asked previously. Oxalic acid, on the other hand, oxalic acid, you should always remember anytime a patient is coming to you in the emergency complaining of consumption of an unknown poison, and there is a coffee ground vomitus, a coffee colored vomiting, it is most likely supposed to be oxalic acid. Oxalic acid is something that chelates calcium. Whenever calcium is chelated in your body, it leads to hypocalcemia, leading to tetany like features. Again, another poison which can cause PCT damage like phenol. It's oxalic acid. And oxalic acid crystals, when they are excreted in urine, that's what we call oxaluria, where you find calcium oxalate casts in the urine. The management of it is just based on gastric lavage and replacing the calcium via rapid infusion of IV calcium gluconate. As I said, hydrofluoric acid, all the other acids cause damage via coagulative necrosis. However, hydrofluoric acid is something which causes liquefactive necrosis. As I said, this is an exception. And due to the liquefactive necrosis, it will exactly behave like an alkali poisoning, where there'll be severe local pain, deep dermal burns. If you can just remember the last slide where I talked of, you can clearly see that alkalis are something which cause deeper injury, whereas acids cause superficial injury, except hydrofluoric acid. And this is the exception that we find here, that in hydrofluoric acid, you have deep dermal burns. And can you just see it combines with calcium and magnesium to form insoluble salts? So there is hypocalcemia, there is hypomagnesemia, which very much resembles an oxalic acid poisoning, where again there is chelation of calcium and there is hyperkalemia. That's all about acids which are relevant enough for the exam point of view. We can keep studying these all over, but because of the time constraint, I have to keep in points which are going to be medically relevant and relevant enough to help you clear your entrances, because toxicology is a very, very, very important segment. It's a very scoring segment, mind you. So the ones who are going to prepare for your entrances in the upcoming days, I'll always tell you, keep a special focus on toxicology, because it's easy, but it's confusing at times if you have not memorized it or revised it in the very end. So keep a special space for for revising toxicology in the end, 7 days or 8 days before the exam. I'll always tell you to revise toxicology once. It's a very, very scoring area. Coming to irritants, we were doing initially we were doing corrosives, and after corrosives we come to irritants. In irritants, we have both forms of irritants. Either it can be metal irritants, it can be non-metal irritants, it can be plant irritants, it can be animal irritants. We begin with metal irritants. Our first metal irritant is arsenic, and the source of exposure is pesticides. Most places right now, I can tell you, most places in this country right now are having water sources which are flooded with arsenic. The water quality is so poor, but unfortunately, that's the water that we're consuming, because arsenic is mainly coming through the either the green fields where the pesticides are being spread, and those that water containing the pesticides is something which is draining into the rivers or the lakes, and that is the water that is being used for human consumption, unfortunately. So from natural sources like drinking water, like soil, from pesticides, the route of absorption is the GI tract. The mechanism of action is something which has been asked, so I'll tell you to be very, very careful about this. It's also a biochemistry question which is integrated. That number one, it leads to inhibition of glutathione metabolism. Because of inhibition of glutathione metabolism, the the RBCs, or the cells in the body, are now very, very susceptible to free radical oxygenation, to oxidative damage, which can lead to hemolysis, which can lead to a bundle of other problems, because the oxidative stress is something which increases in the body. It inhibits an enzyme called pyruvate dehydrogenase. And pyruvate dehydrogenase, is a major enzyme which drives the TCA cycle. So basically, it prevents the energy production in a cell. It also prevents gluconeogenesis. It binds to sulfhydryl groups, and that is exactly the mechanism by which PDH complex is inhibited. The characteristic finding is via the mnemonic arsenic in itself, where A is Aldrich means lines. You can clearly see these transverse bands of white and pink lines that you find on the nail. This is Aldrich means lines. R for raindrop pigmentation. You can clearly see the hands of this patient. This is showing raindrop pigmentation. Rash, red, velvety mucosa. S for subendocardial hemorrhage. This is one of the only toxins which can cause subendocardial hemorrhage. I'll tell you to mark this point and keep it, registered in your memory. E for excessive pigmentation, which can lead to symptoms of Blackfoot disease. The third image here shows Blackfoot disease because of excessive pigmentation and vasoconstriction. And for neuritis, resembles very much a picture of polyneuropathy. And the treatment is iron oxide plus British antilucide, which is the treatment. And C, it also can produce a cholera-like illness, which leads to diarrhea, which is more in an acute arsenic poisoning. The diagnosis is made through urine, so 24-hour urine arsenic is what you take. Treatment, I already told you, it's iron oxide and BAL or DMSA. That is what we use. Now, a typical question was asked 2 years back, if I can recall, maybe it was 2022, when they had typically asked, it was an AIMS entrance examination, and I typically remember this question where they'd asked, what are the features that are found in acute versus what are the features that is found in chronic? So I'll tell you something. Anytime you find Mies lines and you have both acute and chronic in the option, you should always go for chronic, because Mies lines is something that you find usually 2 to 3 weeks post ingestion. It's not an immediate finding. Alopecia is something which is acute. And I will tell you something regarding this alopecia, that is hair loss. So there are basically two poisons. One of the poisons that I've not written here is thallium. Thallium is something which can also cause alopecia. Thallium is something which can also cause something which is called madarosis. What is madarosis? Madarosis is the loss of your eyebrow from the lateral one-third of the eye. So anytime you're having a history of alopecia or madarosis, always think of two differential diagnoses. One is arsenic, one is thallium. Now, if it is asked, you have to look for the other features. If the nail findings are present, if the raindrop pigmentation is present, if there's blackish pigmentation, that moves more in favor of arsenic. If none of these features are present, and it is mainly a shock that has led to the death of this patient, that moves more in case of thallium, which is also called, often it's called an ideal homicidal poison. So that is something which I wanted to tell you, the differential diagnosis of madarosis or alopecia in poisoning. As I said, Mies lines are more for chronic, and hyperpigmentation is again, which is chronic. This is a no-brainer. I mean, hyperpigmentation is not going to happen in one day. It's going to take months to develop. So chronic is hyperpigmentation. Mies lines are again chronic. Encephalopathy, polyneuropathy, you understand, all of these are very common sense things that these will not develop in a day. However, initial acute symptoms may include tremors, may include convulsions or coma. The name suggests that these are acute symptoms, so nothing to you know uh, specify and remember or hammer the brain with. Diarrhea, as I said, cholera-like illness can be found both in acute and chronic features. However, weight loss is something again that is chronic. Mucosal erosions are acute. Mucosal erosions, I mean red velvety mucosa, punched out ulcer-like lesions. Liver shows fatty infiltration, which is an acute feature. In kidney, you have tubular damages, glomerular changes, which again looks more of an acute feature. The nephritic feature, there's a nephritic syndrome like feature where you have casts, where you have dysmorphic RBCs. All of that is a chronic feature that you get in arsenic poisoning. Uh, Coming to the cardiovascular effects, this is something which I want you to know that what is the cause of the Blackfoot disease? As I said, Blackfoot disease is due to intense vasoconstriction. It is due to hypercoagulability of the blood in the peripheral arteries due to platelet activation that is occurring. And in acute phases, because any kind of hyperpigmentation, any kind of vasoconstriction is only going to build up over time. So all of these are chronic effects of arsenic poisoning. The acute effects you find mainly QT interval changes or ST, wave abnormalities. That is what you find. So if what was asked basically is measles in the exam, what was asked basically is alopecia in the exam, what was asked basically is oliguria and uremia in the exam. So these are something which are found mainly in acute poisoning. Because this question has been asked, I wanted to include this slide. I hope you'll take a quick look at these points. Most of these points are no-brainers. You can easily, anytime you hear the word convulsions, coma, these are always going to be acute effects. But take a special look at measles, take a special look at hyperpigmentation, take a special look at Blackfoot disease. These all are chronic changes. Okay, now coming to lead, after finishing arsenic, we come to lead. The source of exposure is occupational exposure, mainly, in petrol pumps, in lead paints, mainly the carpenters or the ones who are coloring the homes, the walls. They're very much exposed to lead poisoning because of the constant exposure. However, in a child, it is mainly due to inhalation. And trust me, I have found one of the cases where I have found this kid who was addicted to smelling petrol. And so he used to, he lived near a petrol pump. So it was one of his favorite hobbies to spend at least half an hour to 45 minutes or 1 hour every day, to be honest, in the petrol pump, where he would just be smelling the smell of petrol or diesel, which looks to be very addictive. But trust me, it's a very bad thing, because in the long run, he started showing features of lead encephalopathy. It's reversible, but then why take yourself to that scenario when you can prevent it? So occupational exposure, lead paint is something for adults. For children, this was asked once. It is always going to be the fumes. It is always going to be the inhalation of fumes, which leads to the lead poisoning. Mechanism of action, very commonly asked question. There are two enzymes which lead inhibits. These have been asked since age long. One is ALA dehydratase, and the other is furochelatase. Please remember this. Apart from this, it also inhibits pyrimidine 5' nucleotidase. Because of all of this, heme synthesis comes to a standstill, and thereby you find typical pattern in the peripheral blood smear, which I'm going to show you in a while. Uh, Lead competes with calcium, so anytime there is lead poisoning, calcium will be chelated, and there will be features of hypocalcemia and tetany. In acute toxicity, it's usually going to be the GI tract via nausea, vomiting, bone marrow due to bone marrow suppression, and the peripheral nerves, which show me a typical polyneuropathy like illness, which is found. In chronic toxicity, however, it's mainly the brain and the kidneys which are affected. And the characteristic clinical findings are, again, by a very simple mnemonic, which is A, B, C, D, E, F. A for anemia with basophilic stippling. I typically told you just a while back, it inhibits pyrimidine 5' nucleotidase, so it inhibits DNA synthesis in the RBCs. It also leads to inhibition of two enzymes, aldehyde and ferrochelatase, thereby inhibiting heme synthesis, which is why you find this typical peripheral blood finding, which is also called basophilic stippling. You can see these stippled RBCs, which resemble like basophils. This is due to the inhibition of heme synthesis that we have. B for Burtonian line, which is a blue stippled line on gums. If asked in the question, is this specific for lead toxicity? No, it can also be found in cadmium toxicity. It can be also found in copper toxicity. Also can be found in mercury toxicity, but it is a finding. What I meant is it's not specific, but it can be found in lead poisoning, most commonly associated with lead poisoning. C for constipation and colic, which is mimicking an intense acute abdominal pain. As I said, these are features of acute toxicity. D for drop, wrist and foot drop due to neuropathy. The wrist drop is associated with the damagement the damage of the radial nerves that you find, and so is for foot drop, which is due to the involvement of the common peroneal nerve. E for encephalopathy, which is again a finding which is an acute finding, mostly seen in infants presenting with severe ataxia, vomiting, lethargy, stupor, convulsions, coma. So these are horrible side effects of lead poisoning, but they happen with time. They don't happen in a day. But when they present in acute emergency and crisis. F for facial pallor. Facial pallor, in fact, is the earliest sign to develop in lead toxicity. Diagnosis, very, very important. It's through blood lead levels, not urine. Why am I repeating this? Because most poisons in toxicology are detected via urine. Even when you talk of arsenic, if you clearly would see, when we were talking of arsenic, just give me a moment. When I was talking of arsenic, you saw this, there was 24-hour urine arsenic that we were using. However, in lead, it's the blood lead levels that we see. The treatment again is either ABAL, which is British antilucide, or DMSA. Or because there's a lot of calcium chelation that happens, you can also do calcium EDTA. This is something which is called lead osteopathy. You can clearly see some osteophytes, which are osteophytes are usually found in osteoarthritis, right? So they're abnormally projecting segments found from the bone. But you can clearly see this that these have a very transparent look, and they look more hyperlucent on the X-ray. And these are findings that we find in the bones. This is what you call as lead osteopathy. This is Burtonian lines. This is basophilic stippling. Please remember the enzymes that it inhibits. It has been asked multiple times, and facial pallor, which is the earliest stage. Coming to metal irritants, mercury. We finished arsenic, we finished lead, we are now in mercury. This is a very classic image. This is an image which is a historical image. You can go to Google, and anytime you type mercury poisoning, this is exactly what you will get. So this is a classic image that you get, which is also what we call Minamata's disease. And this is pink foot disease, also called acrodynia. And I will show you exactly what happens in mercury poisoning. The source of exposure, mercury being an elemental form in the thermometers. It is often found in thermometer spillage, thermometer breakings, and the spillage of mercury occurs. This is one question which has been asked once, that if you're working in a hospital and you suppose you're having a mercury sphygmomanometer and it falls down and breaks and mercury has spilled over the floor, what is the next step? Will you use your hands to clean that mercury? The answer is no. Will you use a broom to clean the mercury? The answer is no. You will simply use a cardboard. That is the question that has been asked. You will use a cardboard to scrape off that mercury from the floor and then put it in a bucket, preferably containing water, and then you will discard that entire bucket. That is the method of dealing with a mercury spillage. These are questions that have been relatively asked with related topics. So I'm trying to cover them right away here. Um, Fish is again a source of organic mercury because the seabed, the waterbed is having a lot of mercury salts in it. Route of absorption mainly is via the GI tract. Sometimes it is through the respiratory tract, but that's very rare. The mechanism of action is very similar to arsenic. It inhibits glutathione metabolism and makes the cells in our body very, very prone to oxidative stress and damage. Acute toxicity will usually affect the lungs and the GI tract, whereas the chronic toxicity will usually cause CNS and renal manifestations. In fact, most poisons that we deal with in toxicology, most of the chronic effects are usually either manifesting in the brain or manifesting in the kidneys. The characteristic clinical findings is what we give by the mnemonic MEATS, where M is mercury lentis. Mercuria lentis is nothing but a brownish capsule or a brownish tinge that you find in the anterior capsule of the lens. Um, there's a diphtheria-like illness which can happen, which can lead to a membranous colitis. Minamata disease is this form where you have this bending of fingers, joint involvements, and severe mutilated forms of arthritis, as you can see. Uh, and in the kidneys, it can lead to membranous glomerulopathy. Please remember this. Membranous, when you study nephrotic syndrome, when you come across membranous glomerulonephritis, one metal which can cause MGN is mercury. E for erethism. Erethism is a neuropsychiatric complication. It leads to personality disturbances, insomnia, retrograde amnesia. A for acrodynia, which is pink foot disease. You can see this. T for tremors, which are coarse tremors. They're also called Danbury tremors, Halter shakes, or Glasgow shake, which often is found in association with the neuropsychiatric features of erethism. As for excessive salivation, the diagnosis is by blood or 24-hour urine mercury level. Treatment is again DMSA. Most metals, I repeat, are cleared by DMSA, that is Suxheimer or BAL, except for certain poisons like cadmium, certain poisons like arsenic. They usually do not or may not respond to just bile. You need to supplement a few other things with them. Coming to, just give me a moment. Coming to non-metals now, we have finished the four important metal irritants that were asked. Now we are moving to non-metals. And when I talk of non-metals, I'll initially take up the most important one, that is phosphorus. Phosphorus exists in two forms. One is white phosphorus, the other one is red phosphorus. The red phosphorus is what you usually find in matchboxes. So you can remember like striking the matchstick against the side of the matchbox, and what you see is the flame getting lit up. So all these firecrackers, all the the fulgeries that we use in Diwali, or for that matter, the matchboxes, all of them are containing red phosphorus, and red phosphorus is non-toxic. White phosphorus is, however, toxic. The mechanism of action is it irritates the protoplasm and thereby causes death of certain cell organelles. The majorly affected organs are liver, bone, and kidneys. What I want you to remember from phosphorus is phosphorus. You can remember it via the matchstick, although it's the red phosphorus which is non-toxic, but it leads to glowing up, right? So anytime there's phosphorus poisoning, you will remember everything will start glowing up, everything will start becoming luminescent, luminescent vomiters, luminescent stools. These are all features of phosphorus poisoning. It's also called smoky stool syndrome or luminescent stools. There'll be a typical garlicky odor that will come out. I want you to all make a flashcard when you are studying. I couldn't include this in this slide. I want you all to make a flashcard of all the poisons with a garlicky odor, because that has been asked at some point of time previously. It also causes liver necrosis. Phossy jaw, however, is not a feature of acute poisoning. It's more a feature of chronic poisoning. This is phossy jaw. You can clearly see multiple draining, foul-smelling, pus-filled fistula, having sinuses which are along the angle of the mandible. And this can only happen if you are inhaling phosphorus on an industrial level, and the inhalation of phosphorus fumes for over several years. Uh, Toothache is the earliest symptom, which can later progress to osteonecrosis of the lower jaw and lead to a phossy jaw. So toothache, unexplained toothache in a patient who is having industrial exposure of phosphorus should make you think about the initial symptoms of a phossy jaw. The treatment is pretty symptomatic. Coming now to the organic irritants, which are plants. We have finished metals and non-metals. Coming to organic irritants, I've tried combining all the organic irritants that are asked usually in the form of one slide. So we have this, you can see the seeds. How will you identify the seeds? So identifying seeds becomes very difficult in the exams, especially. I can only give you one little hint. Anytime you find a seed looking like a cockroach, it's more likely Ricinus communis or castor. So unbroken seeds are not poisonous. However, when broken and crushed, uh, the residue that you have from those seeds is what is poisonous. Castor, however, can also be used as oil. So the ones who paint here, the ones who are good artists here, you can recall making oil painting, and in oil painting, castor oil is a common oil that is used, which is completely non-toxic. You can be chilled out and you can keep painting, keep doing your oil painting canvases again. It's non-toxic, but the residue powder that you get after crushing the castor seeds, they are toxic. The active principle is ricin, and ricin has also been previously historically used as a biological warfare agent. Coming from seeds which look like a cockroach, you can see this, seeds which look like a cockroach, to seeds which look red with the heads being painted black. So it mostly looks like crab, red crabs. If you've seen sea crabs are red in color with the eyes looking black. So crab-looking eyes, they are mainly seeds of Abrus precatorius, which is also called gunchi or ratti in Indian names. The seeds are bright scarlet red with a black spot at one pole. The active principle is abrin. And what I want to tell you is they're mainly used as suey needles. They're used as cattle poison. What they do, what historically used to be done is at the end of the stick or the lathi, what you call in Hindi, these seeds were planted, and they would be used to, these lathis would be now used to hit the cattle. Upon being hit, it used to exactly produce the prick marks, which would resemble either a suey or a needle, or it would exactly look like a viper has bitten these cattle. So this is something which is it's an ideal cattle poison used as suey needles for hitting cattle in the earlier days, and similar to viper snake venom, it is vasculotoxic. Viper snakes are vasculotoxic, and they produce exact similar changes in the body of the cattle like a viper bite. Coming to croton, the seeds, remember, they'll resemble the castor. So castor seeds and these seeds, you can easily see They also resemble like cockroaches, but these croton seeds, when they're crushed, they yield the oil, which is toxic, which is very contrast to what I said for castor. Castor oil is non-toxic. However, croton oil is toxic, and the active principle is croton or crotonic acid. Coming to semicarpus or bilava or bilavanol, which is the active principle is semicarpol or bilavanol, which is used as a marking nut. You can still find these in some old tailor shops in India, where if you visit some peripheries where the tailors are using these seeds for marking, and these seeds are black and they're heart shaped with a rough projection at the base. They're called marking nut, and because of the sharp edges, they can produce bruises on the body, which are artificial bruises or induced bruises. They're not caused due to an injury. You can self-inflict these bruises, and if they are applied to the eye, they can also cause conjunctivitis. So irritation, itching, and a painful blister with acrid serum is what defines the typical pattern of injury with these seeds, and hence it can also be used as for producing an artificial bruise or malingering. So if asked which seed, which organic plant irritant is used as a method for malingering or taking up a bruise, it's always semicarpus. Coming to calotropis, the roots are extremely toxic. The active principle is calactin, calotropin, or calototoxin. In the skin, they can produce blisters. Eye, again, conjunctivitis, very much like semicarpus. The root, as I said, is poisonous, but please remember it's not just poisonous to humans. If you're asked which is one organic toxin which is also poisonous to poisonous snakes, the answer is calotropis. This root is not just poisonous to humans, it's also poisonous to all the venomous snakes. Next, capsicum or chili. You've, I'm pretty sure you've come across these flowers and the seeds. The, the active principle is capsaicin, and it produces a severe serotonin mediated rush or a serotonergic crisis. Let's say serotonergic flushing. Let's be honest, in the body, which leads to redness. It leads to painful contact dermatitis in the hands. If these seeds of the chili are, if the chili seeds or capsicum seeds are crushed and then applied on the hand, they can lead to human hand syndrome, which is nothing but blistered, painful oozing fluid, and painful contact dermatitis that you can get with these seeds. Coming to animal irritants, which are snakes, you have two forms of snakes. One is a poisonous and a non-poisonous. And the questions in exams, I don't know why, but they still ask you about how to differentiate a poisonous snake from a non-poisonous snake. The head scales are always going to be small, and the tail is going to be compressed. Poisonous snakes are something which have a nocturnal habit. They usually, come out at night, and this is something which everyone knows, that their bite has two fang marks. So head snakes are usually, the head scales are usually small, the belly is usually large, and the scales of the belly will usually cover the entire belly. So these are the main 3 points of differences. Number one is a compressed tail. Number two is a small head scale. Number three is a large belly scale. So how can you remember it? The way that I usually did back in my time when I was preparing for the exams is, because they are poisonous, they'll want, and they need food to survive, right? So because they're poisonous, they want to kill a big prey, and because for they want to kill a big prey, they need a big belly, and hence the belly scales are large and it covers the entire belly. The head scales are small. There are only two types of poisonous snakes which have a large head scale, which is very much in contrary to what the other poisonous snakes have. Number one is cobra, where the third supralabial scale is large, and crate, where the fourth infralabial scale is large. So these are the only two poisonous snakes having large head scales. Cobra, the third supralabial. How do you remember? C for cobra. C is the third alphabet. It's the third supralabial. Crate is the fourth infralabial scale, which is large. Otherwise, all the other features are same in them. That they have a compressed tail, they have nocturnal feeding habits, they have two fang marks when they bite. When it comes to a non-poisonous snake, uh, head scales are large, the belly scales are small, and the tail is not usually compressed. So these are basically the images to see. And clearly see there's a triangular shaped head. The body is more narrow than the head, the large hollow fangs, and you can see the scales underneath the tail in a single row. Whereas in case of a non-venomous snake, you can find that there's a small teeth, not big fangs, and scale normally underneath the tail in a double row. Usually, when I talk of snake families, you have usually the Elapidae and the Viperidae, which are found to be harmful to humans. In Elapidae is all about the cobras and the allied families of cobras. Viperidae is more about vipers. Vipers in India, you have Russell's viper, which is very common in the northeastern belt of this country, and pit viper basically. And when you talk of Elapidae, that's cobras. You have either the terrestrial form of cobras or the sea form of cobras. The sea form of cobras is what you call sea snakes, hydrophinae. Whereas in the terrestrial form on land, you have the king cobra, and the crate. In India, it's mainly the cobra, the crate, and the Russell's viper, which are usually found. And in fact, I'll be showing you this slide. This is known as the big four: the Indian cobra, the saw-scaled viper, the common crate, and the Russell's viper. These are the main four species of snakes that we find in India. And whatever anti-snake venom is being prepared in India, mainly by the labs in Chennai, are the ones where we are preparing the anti-snake venom that is effective only against these four species of snakes. For other poisonous snakes, it may be effective, but not as efficacious as it is for these four varieties of snake. This is a Government of India protocol that came out, I think last year, where they had made this mnemonic of first aid protocol as to what to do, being a non-medical person, what to do when you have someone in front of you who has been bitten by a snake. This came up because of the excessive dependence in India to take these patients who have been bitten by snakes to the to the forms of artificial medicine, or to saints, on like the people who are not medically trained, to them for either giving mantras, or to cast spells on them so that they get well. But the Government of India strictly says now that if there's a snake bite, this is what you need to follow as a first aid. One is carry no right. So under carry no right, what is carry? Do not allow the victim to walk even for a short distance, because this will help in spreading the venom, and that will lead to more fatality. Especially if the bite is in the leg, please do not make this person walk. No to tourniquet, no to electrotherapy, no to cutting, no to pressure immobilization, and a big no to all the serials and cinemas that you find where the girlfriend is kissing and sucking out the poison from the boyfriend's hand or the leg. No kissing, no sucking of poison. So all of this as a no. And are for reassuring the patients. 70% of all the snake bites are usually non-venomous. 50% of the bites are via venomous species, and uh, and 50% of these bites, which are actually by the venomous species, can actually envenomate the patient. What do I mean by this line? I mean that even if it's a venomous snake that has bitten you, there is lesser chance that it will spread throughout your bloodstream. It can cause local destruction of tissues. The poison can spread to the local tissues, the local skin, to the epidermis, to the dermis, but usually 50% of the times it does not spread to the other organs of the body. I for immobilize the patient in the same way as you do for a fractured limb. You just stabilize that limb or stabilize the part that has been bitten. Use bandages or cloths to hold the splints. Do not tie the bandages. Do not block the supply or do not apply pressure. Do not tourniquet. As I said, do not suture. Please do not suture. Do not ligate. Do not suture, because they can be dangerous. GH is get to hospital immediately. Don't go to babas. Don't go to sadhus for snake bites. At least traditional remedies have no proven benefit in treating snake bite. And T is tell the doctor of any systemic symptoms that manifest on the way. What do you mean by systemic symptoms? So if it's either a neurotoxic bite where you can have features of ptosis, these are these are pictures that I've collected from different patients. So you can find features like ptosis, and you can find features of conjunctival edema or emesis, which are due to the bite by a vasculotoxic snake like Russell's viper. You can find gum bleeding, which is very common in, again, viper bites. Local reactions, you can find ecchymosis, edema, swelling. So all of these are symptoms which you need to notify to your doctor. Once inside the hospital, now this is something for the medical personnel to deal with. Whenever there's a case of suspected snake bite, the first thing that you do is you first take a proper history. If there is no history of bite, but the patient is showing you symptoms, one snake that should always come to your mind is crate. This is something which I'm repeatedly going to tell you. In places like West Bengal, like Madhya Pradesh, Chhattisgarh, Chennai, I mean Tamil Nadu, these are the places where crate is so common in usually the months of July, August, September, when the rains are just peeking in or about to go. That this is the time when crate bites are very common. Crates are usually found in those mud houses, and you will not be able to find a bite. It's usually so small, it's very much like a mosquito sting. That's what a crate bite is. But crate bite is one of the most lethal bites because it is purely neurotoxic, and it will lead to an ascending form of paralysis initially. So I still remember this patient that I had saw that I had seen back 4 5 years back, and it was a crate bite where the patient did not present with any significant finding on the skin. Uh, it started off with mild weakness that he felt when he woke up in the morning, which gradually progressed to his limbs, over his limbs to the waist, and by the time we were seeing him, it had actually progressed till a point where his diaphragm was paralyzed, and he actually had to be intubated because he was having diaphragmatic paralysis and respiratory failure. He did recover, but then, as I said, if anytime you're finding neurological manifestations in a patient, ascending weakness coming from a family where there's mud houses, the patient sleeps on the floor, please rule out a crate bite, because it's one of the worst bites to get. So neuropsychiatric symptoms with no local signs, severe abdominal pain, vomiting, ascending weakness is something which should make you suspect a crate bite, and you will give ASV, that's anti-snake venom. AN is atropine and neostigmine, because that is what will relax the nerve endings, create better synaptic transmission, and ventilation in severe cases if there is diaphragmatic palsy and respiratory failure. Coming to, if there is a clear visible bite wound that you find, which is called an overt bite, as I said, maximum times it will be a non-venomous snake. 30% of the times it may be a venomous snake. If it's a non-venomous snake, just give reassurance to the patient, treat anxiety, treat the palpitations and the tachycardia which is happening. If it's a venomous snake, most of the times it's going to be a dry bite. If it's at all symptomatic, that is, you have progressive swelling, you have neuroparalytic features, you have bleeding from different sides, or you have a clear muscle necrosis which you're seeing. Muscle necrosis is very common found in the sea snakes. So sea snakes have myotoxin, and these myotoxins can lead to rhabdomyolysis. Rhabdomyolysis pictures, it's something where you have hyperkalemia, you have oliguria, you have total acute tubular necrosis, and the muscle also starts getting necrosed. So muscles ache, muscle swelling, involuntary contraction of muscle, compartment syndrome like features should always make you think in the line of sea snake bite. You will give ASV with supportive treatment. Because of renal failure, you will have to consider dialysis. For vasculotoxic snakes, which come with gum bleeding, which come with conjunctival ecchymosis, uh, these patients usually may present to you with shock, bleeding, acute kidney injury. You again plan for blood transfusion, FFP transfusion if there's DIC. You check for D dimers. And one of the best ways that you can check out whether it's a vasculotoxic snake is by doing this test, which is called 20 WBCT, which is also called the whole blood clotting time, where you basically take the blood of a patient and you keep it for 20 minutes. Usually in you and me, a normal patient or without a snake bite, or in case of a non-venomous snake bite, the blood should clot in 20 minutes. But if the blood does not clot in 20 minutes, then that is what you call as 20 WBCT positive, and you can suspect that maybe the bite was through a venomous vasculotoxic snake bite, which is mainly a Russell's viper or a saw-scale viper that you find in India. Neuroparalytic features, as I talked to you, it may often come without a bite mark, cobra or crate. Cobra, you'll find a bite mark. Crate, you may not find a bite mark. Ptosis, diplopia. Diplopia is due to the involvement of the sixth nerve. Ptosis is due to the involvement of the Muller's muscle. Please note this. This is another question which has been independently asked. Ptosis is due to the involvement of the Muller's muscle, Muellers. Diplopia is due to involvement of the sixth nerve. Dysarthria, dysphonia, dyspnea, dysphagia, paralysis, all of these are involvement 9th, 10th, 11th nerve. 9th is the glossopharyngeal nerve, 10th is the vagus, and 11th is the spinal accessory. Mainly the 9th and 10th nerve, leading to features of dysarthria, dysphonia, dyspnea, and dysphagia, and paralysis. As I said, look for signs, look for features. Even if you don't find a bite, look for these neuroparalytic features, give ASV, give atropine neostigmine, ventilate. If there's a progressive painful swelling with local necrosis, blisters, compartment syndrome, very much resembling like a myotoxin, but not rhabdomyolysis, because the potassium levels are still fine. You don't find the creatine levels, the creatine kinase levels are still normal. All of this should make you think of a viper bite, and you just treat with anti-snake venom. This is just a simple flowchart of the entire thing that I explained. You can quickly refer to these PDF to the PDF for the doses which are given. The doses are not important at your level for the entrances, but definitely if you're someone who's managing emergencies in the emergency working as a doctor, you should be very clear with the doses that have been given. And I'd rather tell you, because snake bite in itself is a very independent topic. I can clearly talk about snake bite for around 45 minutes to 1 hour. It's that vast a topic, especially when it comes to the management. So it has a separate protocol. You can go up to the internet, you can look at the Government of India regulations, especially for the ones who are working right now in the emergencies in India. You can look up to the Government of India journal, which speaks for the specific protocol that is to be followed for a patient with snake bite. What do you do in cases of early bite? What do you do for cases which are presented late to you? What is the exact management? What is the dosage? You can always refer to that. Okay. Now coming to after I've completed the organic irritants, the animal irritants, the plant irritants, it's now come to the time to come to the neural poisons. When I talk of neural poisons, I specifically mean poisons which can either make you feel sleepy, drowsy, or poisons which can make you feel active. So deliriants are poisons which give you that feeling of delirium. It's like you're feeling as if you are at the top of the world. And somniferous poisons are something which can depress your state, make you feel slow, slothy. So I'll talk of the somniferous poisons. Under somniferous poisons, the most important one is opium. And opium or poppy is derived from Papaver somniferum. That's the name of the plant. And the juice that is found from the unripe capsule. It's the unripe capsule. This is a question in itself. It's the unripe capsule, which when cut, it leads to a dried brown residue, which is toxic. However, poppy seeds are non-toxic. If someone is here who is belonging to West Bengal, you can relate to this. Poppy seeds are what we use for cooking, and it's one of our favorite delicacies. So poppy seeds are non-toxic. They're used in cooking. However, the juice obtained from the unripe capsule of the fruit is toxic. Anytime there's opium poisoning, it typically resembles morphine poisoning. There's coma, there's pinpoint pupil, there's respiratory depression. You can simply remember it that it will be a surge of all the parasympathetic systems in the body. So coma, pinpoint pupil, which will be due to the parasympathetic activation in the eye, which will lead to meiosis and respiratory depression. The antidote is naloxone. So please remember, anytime you have opium poisoning or morphine poisoning, the drug of choice in the emergency is naloxone. However, if you're asked what is the maintenance therapy, maintenance like you have managed the patient, emergency is over, you are discharging the patient and now keeping the patient on maintenance therapy in cases of morphine addiction, then it is naltrexone. Please don't confuse these two names. Naloxone, naltrexone sound similar. Naloxone is when it is emergency. Naltrexone is what you do when you have to maintain. Now, coming to heroin, which is also given by these names, the names are sometimes asked. It's also called brown sugar or smack or dope. It is a semi-synthetic derivative of morphine, also called DAM or diacetyl morphine. It can either be given by skin injections or inhaling. These two names have been asked previously, hotshot and speedball. How you remember it is hotshot, HS, that is heroin and strychnine. Speedball is heroin and cocaine. Coming to Datura, which is a deliriant. We have finished somniferous poisons. Now coming to deliriants. Datura is one of the major deliriants. You can see this is the flower of Datura. Looks like a beautiful white flower. And this is the fruit. This fruit is also called thorn apple. And it's one of the most poisonous fruits to be ever found. Datura is, we remember the clinical features of Datura by this age-old mnemonic. It's called hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad as a otter. So basically, there's a serious parasympathetic oversurge, a lot of acetylcholine being released that will lead to dry, hot skin. The temperature rises up to almost 42 degrees Celsius. You can find a red rash on the body. There is going to be a dilatation of the pupils. There's going to be loss of accommodation, diplopia, dryness of the mouth and throat, dysphagia, dysarthria, delirium, drowsiness, and death ultimately due to respiratory or cardiac failure. The active principle is atropine, hyoscyamin, or scopolamine. All of this has been asked previously. Uh, Carphologia is a unique feature. Carphologia is also a neuropsychiatric feature where the patient feels like there are threads hanging from the top of the ceiling and he's keeping on pulling these threads. So carphologia is a unique feature which is found to datura poisoning. It's also called pulling threads. It's used by criminals to passengers prior to robbery, rape, and kidnapping because these criminals can take use of this fruit. First of all, it's readily available. It's also called a roadside poison, accidental poison because these flowers, I mean, the fruit often resembles the normal green apples that we usually come across. So it's often called an accidental poison, also called a railway poison because earlier it was very routinely being used by robbers in the trains to finish their acts of robbery or kidnapping. The treatment is physostigmine, as I said. We need to cut off that parasympathetic surge which is happening. and the best way of doing it is by giving an anticholinergic, which is phytophthagmine. Okay, so features of datura poisoning is something which is very important. If you're like asked to revise a poison whose clinical features you need to remember, one is OP poisoning, that's organophosphorus poisoning, which will come in a few minutes, and the other is datura poisoning, which should be the two clinical features that you should always remember. Please remember: hot as a hare, blind as a bat, dry as a bone, red as a beet, and mad like a hotter. You can remember the clinical features very much via this way. Okay, coming to uh, coming to other deliriums, you have cocaine, you have cannabis. Cocaine is something which can produce a hyperadrenergic state. It was earlier used very much as local anesthetic. It's still used, but not very much in India. It can cause intense vasoconstriction and thereby leading to features of MI, features of stroke, or features of gangrene and ischemic colitis. Because of its sympathetic overcharge, it can lead to hyperthermia and mydriasis. You can clearly see this. This was asked directly as an Ames question. I've directly picked up that image that was asked in that paper. And you can see this. This is a CT scan, which is clearly showing bags of cocaine that this patient has swallowed and kept inside his abdomen so that he is not caught in the airport. This is also called body packer syndrome. And these are the packs of cocaine that was discovered from this patient while he was being screened in the airport. A CT was done because he was found to be suspicious. A CT was done, and we found typical cocaine-filled bags, which was there in his abdomen. But the risk of this is if one of these bags rupture, then there's a severe chance of cocaine intoxication and poisoning that can happen. Because of intense hyperadrenergic crisis and vasoconstriction, you can find nasal septal perforation, a very important asked question previously, and gangrene of the heart palate. So gangrene of the septum, nose perforation, palatal perforation are something which you find. These two features are usually what you find in chronic cocaine abuse, gangrene and nasal septal perforation and palatal perforation. Black tongue and teeth. Can you remember one another poison that we were talking in the beginning where everything was black? On postmortem, it was H2SO4. As I said, H2SO4 will make everything black, only keep the teeth white. Coming to another feature of chronic cocaine abuse is Magnan syndrome, where there is tactile hallucination, there's itching sensation, and the patient feels as if there is a continuous bag of worms or insects which are crawling and climbing up his skin, which is also called formication. So Magnan syndrome is associated with chronic cocaine abuse. Coming to cannabis, cannabis, its active principle is cannabinol, which is converted to tetrahydrocannabinol, which is the better answer to give. If you're ever asked what is the active principle, it's THC or tetrahydrocannabinol, which is because cannabinol is inert and it's converted to THC on heat. There are various forms in which cannabis can be taken. Bhang is through the leaves. Ganja is through the flower tops. How I remember it, ganja is what we call a person who is bald. And the head is bald, the head is on the top. So ganja is flower tops. And hashish or charas is the dried resin that we find from the cannabis plant. Chronic cannabis poisoning. This is a mnemonic which helps to think of all the features. It's called favorite. So cannabis is favorite for the ones who are dependent on it. So F for flashback phenomenon. They keep having flashbacks of memories that they earlier had. They keep thinking that maybe it's happening in the present when those memories have been past ones. They feel that they are coming back to them again. A for amotivational syndrome. They usually don't have the intensity or the energy to start their day or do tasks which are typically socially demanding. VO for vomiting. R for run amok. It's a homicidal impulse to kill. Basically, in a patient of chronic cannabis poisoning or overdose of cannabis, this patient will initially want to kill somebody, so he will kill a person and then run around the house and then hide in the most cornermost part of the house and then commit suicide. So homicidal impulse to kill followed by suicide is something which is called run amok. I for insanity. So under the Criminal Responsibility Acts of India, it clearly says that anytime a patient, I mean a person who has been suspected to be an accused cannot be held responsible for the act if he or she is under the influence of any substance abuse like alcohol or cannabis. So anytime a patient on cannabis has committed a crime, then he or she is not going to be responsible for the act. T for testosterone decrease, it can cause low libido in patients who are having chronic cannabis abuse. Coming to Spinal poison now, which is strychnine or nux vomica. These are the seeds. The seeds have been repeatedly asked. This is the fruit. The fruit has not yet been asked, but if ever it is asked, I would want you to remember me and mark this. This is the seeds, which are typically called cuchilla. You can see it's a plano-convex form of seeds. The center looks a little more depressed, and the features are usually convulsions, generally of the generalized tonic-clonic type. The reflexes are increased, mind is conscious, pupils are dilated, and you have certain positions. This is the typical arching back position or the opiostotonus position, which you find. This is something which is the diagnostic image for tetanus poisoning. So strychnine very much acts like tetanus poison. So you can find very similar things in tetanus poisoning as well. In a while, we'll be differentiating what are the features of strychnine poisoning versus a tetanus poisoning. So arched back is opiostotonus. Emprostotonus is arching forward, and pleurotostotonus is what you call as bending sightward. So you remember this is something that you remember opiostotonus. So O is something you have to arch an O forward and backward. So that is how I remember opiostotonus. Emprostotonus is arching forward, E and F. F is forward, so emprostotonus, E and F go together. And pleurototonus is something where you bend sideward. Rhizus sardonicus is a typical smile that these patients give. It is due to the fixed contraction of the facial muscles, which result in a grim. It's mainly due to a trismus-like feature due to the involvement of the masseter muscle. This has been a question previously asked. Which muscle involved in strychnine poisoning or tetanus poisoning leads to these features of Rhizus sardonicus? It's mainly the masseter muscle which is involved. Strychnine poisoning, as I said, it may resemble tetanus poisoning. So you can see this clearly. There's a difference. I think the slide is not very clear. I'll try to dictate it out to you. So in tetanus poisoning, there's always going to be a history of injury with an old nail or a rusted iron object. The onset for tetanus poisoning is going to be gradual, whereas strychnine, because it's usually ingested via seeds, the onset is in suddenly and in hours. The basic point of difference, which you need to remember, is tetanus is a presynaptic toxin, whereas strychnine is a postsynaptic toxin. So it just depends on the site of the neuromuscular junction where it's acting. Trismus or lockjaw is something which you find more in tetanus, and strychnine poisoning. It does not start with trismus. It can later have trismus, but in tetanus poisoning, you usually have a very earlier onset of trismus or lockjaw that you find. The muscular contraction is another important difference. So point number 3 and point number 5 are two very, very important points. Number 3, that is strychnine poisoning is postsynaptic, tetanus is presynaptic. And number 5, that is the muscular contraction that you're finding. This contraction of muscles that you're finding. This is usually relaxed in between the convulsions. So you'll have a phase of convulsion where this patient will have this typical posture of opiostotonus, followed by relaxation of these muscles. Again, when the convulsion begins, after a while, there'll be again another phase of these tense muscles. However, the contraction of the muscles and tense muscles, this rigid posture is maintained entirely throughout in tetanus poisoning. Be it a phase of seizure or not, these patients will continuously keep being in this posture. Tetanus is, both of them are fatal, but the fatal period of strychnine poisoning is very, very, very fast. It can kill you in literally 1 to 2 hours. The chemical analysis, of course, will on strychnine poisoning, you will find strychnine. However, in tetanus, because it's mainly due to injuries and unvaccinated individuals, there'll not be any toxin found. Three things which I wanted you to know. So among these seeds, even one crushed seed is fatal. Even one crushed seed is fatal. Intact seeds, unless crushed, they are non-toxic, but a crushed seed, even one of them is fatal. So often a question that is asked, which of the uh, poisons that we have has the minimum fatal dose? Strychnine is one of them. Postmortem caloricity, something very, very important because of the rigid stiffness in these muscles, because of a lot of ATP that gets accumulated in these muscles. You usually have a heatening of this body following death. Usually, our body cools after death, which is called algor mortis. But in these patients, you have postmortem caloricity. Early onset and shorter duration of rigor mortis, that is due to the persistence of ATP that you find. Because of this, there's early onset and shorter duration of rigor mortis that you find in these patients. Coming to cardiac poisons, I always remember this cardiac poisons as car dona. So dona has a car, and these are the poisons. So car say cardiac poisons, and dona D for digitalis. You can look at these beautiful flowers. The active principle is digoxin or digitoxin. It's a pharmacological drug used in patients of heart failure. it inhibits sodium potassium ATPase pump, and the other mechanisms is something which I'm very sure you're aware of from your pharmacological knowledge. DONA, as I said, DONA has a card, D for digitalis, O for oleander, N for nicotine, and A for aconite. When I talk of oleander, you have two forms of oleander. The names have been asked. One is pink, one is yellow. The scientific names, unfortunately, have been asked here. So pink oleander is Nerium odorum, whereas yellow is Cerebra thivacea. The active principle in yellow oleander is cerebrin or thivation, whereas for pink oleander, it is Nerium. Coming to aconite, uh, in aconite, you have both the flowers and the root, which are poisonous. Please don't confuse these flowers with these flowers. They look very similar, but you should have a very, very clear look at these flowers. These flowers do not taper in the end, whereas on these flowers, you can see there's a clear tapering, a round shaped, pyramidal shape, rather, to be honest, tapering that you find in these flowers. In aconite, the entire plant is poisonous, whereas the root is the most toxic part. Active principle is aconitin. Most important features, number one is tingling and numbness in the mouth. Tongue pharynx is twitching. Xanthopsia is yellow vision. And you have hippus. Hippus is alternate dilatation and contraction of the pupil that you find. It can lead to bradycardia, AV block. Sorry, somebody by mistake it got written as EV block. It will be AV block. Bradycardia, AV block, and ventricular ectopics are something which are found with the cardiac side effects. Nicotine, all parts are toxic except the ripe seed. In acute phases, it can cause cardiac arrhythmia. It can act as a GI irritant. In chronic, it can cause something called toxic amblyopia. The treatment, this is something which has been newly added. Inversin is a drug which has been found to be acting as an antidote to nicotine poisoning. Okay. Coming to agricultural poisons, in fact, this is something which I really want you to pay full attention on, because so many questions have been asked on agricultural poisons over the years. You usually have organophosphorus chemicals, you have carbamates, you have organochlorine, and you have others. Mainly, we'll talk of organophosphorus. In organophosphorus, you have phosphorylation of the acetylcholine esterase, enzyme. And what does usually what does acetylcholine esterase do? It clears off the remaining acetylcholine in the neuromuscular junction, and it sends it back to the cleft, right? But in this case, because there is a phosphorylation of acetylcholine, there will be an irreversible inhibition of these acetylcholine esterase inhibitors. A lot of acetylcholine is going to accumulate at the neuromuscular junction, and it will lead to and a cholinergic crisis that you find. So cholinergic crisis will typically resemble a parasympathetic surge that you find in these patients. We look at the symptoms in a while. So HETP, malathion, parathion, these are all things which are associated with organophosphorus compounds. The symptoms are going to be very severe. On the other hand, carbamate very subtly resembles OP poisoning. The only difference being OP poisoning has an irreversible inhibition of acetylcholinesterase, while carbamates show a reversible inhibition. The symptoms hence are mild because the symptoms are reversible. Coming to organochlorine compounds, it's mainly the pesticides, Enrin, DDT, which is used as a mosquitoes, indoor spray killing. Earlier it was used, now it's been gradually decreased. And it is the only agricultural poison that can cause mydriasis. It's a point that has been asked previously. Most agricultural poisons like OPs, like carbamates, they cause meiosis, but the only one that can cause mydriasis is DDT poisoning. So as I said, you can clearly see this. Because of acetylcholinesterase enzymes which are inhibited now, there is a cholinergic crisis, and because of cholinergic crisis, neuropsychiatric features are there. There is persistent memory defects, cognitive defects, learning defects, and at the same point of time, NMDA is activated. Because of NMDA overactivation, there's a calcium channel activation which is happening, and it can trigger apoptosis or mitochondrial dysfunction. Last slide, which I'll try to take you to, from OP poisoning. So as I said, typically when I'm studying OP poisoning, I should think of all the glands which are having parasympathetic supply. So the glands are mainly having parasympathetic supply. In bladder, there'll be an increase in urinary frequency. It can lead to incontinence. CVS, we know what acetylcholine does to the heart. Bradycardia, hypotension. Respiratory tract, there'll be increased secretions. So basically, all glands will show increased secretions. GIT, abdominal cramps, vomiting, diarrhea. All the exocrine glands will show increased salivation, increased lacrimation, perspiration. In the eyes, parasympathetic system causes meiosis, blurred vision, and these are the muscarinic side effects of acetylcholine. Acetylcholine, we know, also binds to the nicotinic receptors, and in the nicotinic receptor, because of the nicotinic side effects, it will cause flaccid paralysis and fasciculations. In fact, I remember a question which was asked once upon a time, that muscle fasciculations which happen in in OP poisoning are due to which side effects? Is it the muscarinic side effects or is it the nicotinic side effects? The answer is nicotinic. In CVS, as I said, although you find bradycardia and hypotension, however, if the ganglia is involved, and because the ganglia are usually nicotinic, these will lead to tachycardia or transient hypertension. Transient is the most important word. You will never find a persistent hypertension in these patients. Patients will initially show a transient hypertension, transient tachycardia, which will later become bradycardia, AV block, or hypotension in the long run. Muscarinic and nicotinic, both effects are also found in the CNS, where there's dizziness, there's lethargy, there's fatigue. And I'll tell you this, I can remember when I was doing my MBBS from Bankura Medical College, West Bengal, we used to find so many cases of OP poisoning. It is a typical kerosene-like order. This patient will, the relatives will come and say, initially before they try to talk to you, you'll assume that it's kerosene poisoning, but they later come up to you and say that no, it's not kerosene. Maybe this the patient had something which was used as an agricultural pesticide. That is when you suspect OP poisoning. But the typical odor that you get from these patients is a typical kerosene like smell. If you don't treat these patients well, I mean, let's first come to the treatment. So the treatment for nicotinic symptoms is pralidoxin, which is also called PAM. And I just want you to know that oxymes are supposed to be started as early as possible. With time, if you delay the initiation of oxymes, then their effect wears out. Muscarinic side effects predominantly, and CNS effects, because it's acetylcholine which is causing all of these effects. The antagonist of acetylcholine is atropine, and atropine is hence used as the drug of choice for muscarinic symptoms and CNS symptoms. For nicotins, it's oxymes. And for convulsions, you can give a symptomatic management of IV diazepam. For pulmonary edema and bronchospasm, which develop, again, symptomatic management with oxygen, with intubation, or positive pressure ventilation is concerned. What if you do not treat these patients at early, or do not treat these patients properly? If the dose is not adequate, if the dose of atropine is not adequately done, then 1 to 3 days after the attack, you find this typical syndrome, which is called intermediate syndrome, which was asked in an AIMS examination 3 or 4 years back. It's due to inadequate treatment. There's proximal muscle weakness. There are multiple cranial nerve palsies and neck flexor palsy. If left untreated, for a long time, either these patients die, or if partially treated after a very long time, say 1 to 4 weeks after the attack, then there's a delayed syndrome which mimics distal sensory motor polyneuropathy. The diagnosis is by true RBC cholinesterase, which correlates with the clinical features. However, true RBC cholinesterase is a difficult test to do. It's often very costly. So in India, in most settings, we initially will definitely like to do a pseudocholinesterase level test. However, true RBC cholinesterase is the test of choice that is usually done because it correlates classically with the clinical features of OP poisoning. Coming to these slides now. So the set of, I think, 2 or 3 slides that I've included. This is one slide. Give me a moment. So this is one slide. This is the other. So these 3 slides that I've included are summaries of all that you need for your exams. Trust me, these are the only one-liners that have been repeatedly asked. So please take a very quick look at them. When I talk of appearance of gastric mucosa in certain poisonings, I want you to strictly remember arsenic, which shows a red velvety mucosa. H2SO4, I've already told you, everything will turn black. Carbolic acid shows a thickened mucosa, a gray leathery mucosa. HNO3, I told you, it causes xanthoprotic reaction, picric acid produced, hence everything turns yellow. HCN is pink, or cherry red, as we call. KCN is brick red. So if there's someone who can differentiate me cherry red and brick red, I'm glad, but I don't know how to differentiate them. But in the question, anytime you hear a pink mucosa, gastric mucosa, or a cherry red mucosa, it's HCN. Anytime it is brick red or brown, it's KCN. Phosphorus, it is either yellow or gray white. You can remember this by the fact that phosphorus causes everything to be luminescent, and any luminescent structure is either bright white or it is yellow in color. Now coming to the odor of certain toxins, I told you to make a list of all toxins which have a garlicky odor. So arsenic is one of them, phosphorus is one of them, and malathion, thallium is one of them. So I usually remember this mnemonic called ALP, which is ALP in itself stands for aluminum phosphide, which has a garlicky odor. A for arsenic, and arsenic mimics very much with thallium, as I said. So arsenic, thallium comes in, and E for phosphorus. Which of the poisons are odorless? Thallium is the most common one. I want you to remember thallium very much here because of this property that it is odorless, it is often used as a homicidal poison. Zinc phosphide has rotten fish. You can remember this. Cannabis has odor of burnt rope, which has been previously asked. Everything that I've included in these slides are previously asked questions. Carbolic acid has a phenolic order. Cyanide, multiple times asked, smell of bitter almonds. Rotten egg, we know this right from our chemistry days. H2S has rotten egg smell. As I said, smell of kerosene comes from OP poisoning. Now, if there's one slide that you will ask me that, if there's one slide that I need to revise with toxicology one night before my exam, is going to be this slide, antidotes with their poisoning. From here, I typically want you to remember amyl nitrate, which is used for cyanide and hydrogen sulfide poisoning. I want you to remember atropine, which is used as carbamate poisoning. Nicotine, uh, which is treated by via bupropion, and hence is one of the major constituents of chewing gums, nicotine gums, or nicotine tablets, or nicotine patches that we have. I want you to remember, calcium edetate, which is also called EDTA, calcium EDTA, which is used for cadmium poisoning, cobalt poisoning, copper, lead, magnesium, mainly all the divalent cations. Can you just see nickel is divalent, Ni2 plus, zinc is divalent, Zn2 plus, cadmium Cd2 plus, chromium Cr2 plus, cobalt CO2 plus, copper Cu2 plus, lead Pb2 plus, magnesium Mg2 plus. All the divalent cations are usually having calcium EDTA as their antidote. Calcium gluconate is something which I want you to remember for oxalates mainly. As I said, oxalates will chelate calcium, so please remember this. I want you to remember iron, which is despiroxamine, alcohol withdrawal, which is diazepam. I want you to remember BAL, which is dimercaprol for arsenic, for copper, for lead, mercury, nickel, and gold. And I want you to remember DMSA, which is for lead, ethanol, which is an alcohol in itself, but is used for methanol poisoning or ethylene glycol poisoning. If you're asked about what is a poisoning where the patient has consumed an alcohol which is used as an antifreeze agent, it is ethylene glycol. If you're asked about an alcohol which on exposure, which on intake can lead to blindness, also a part of the Hooch tragedy, it is methanol. Digoxin, digitoxin, oleander, these are all having a monoclonal antibody as a fragment or an antidote to it, which is also called the FAB fragment. So digoxin has its antibody called digibind. Propranolol or any other beta blocker toxicity is treated by glucagon. Benzodiazepines are treated by flumazenil. And cyanide, as I said, is having an antidote called hydroxycobalamin. This is an extremely, extremely important slide. I'm reading through the most important things that you need to remember. And I'm hoping that, you can, when you get the PDF, you'll be just highlight these points because they are so, so, so very important. Coming to the urine colors that we have, olive green urine on standing. I said this is carboluria, which is for carbolic acid. We are basically doing a revision of the entire slide that we did. Black is due to phenol, which is ochronosis, I told you. Opaque appearance, which settles on standing. You may not remember this, it's okay. Orange or orange red urine is very common with the antitubercular drug rifampicin or iron. Okay. Coming to the color of postmortem lividity, I want you to remember this. Carbon monoxide is cherry red. Cyanide is brick red. Please, please, please remember this as well. In a while back, we did the postmortem staining of gastric mucosa. One was brick red, one was cherry red. So you can remember that. For hydrogen sulfide, it is blue green. For potassium cyanide, it is deep blue. Hypothermia, it's bright pink. In opium poisoning, the postmortem lividity is black color. So and for phosphorus and acute copper poisoning, it's dark brown. Mainly cherry red, dark red. Cherry red, brick red, dark brown, blue green, deep blue, and bright pink are the ones that have been asked. Last but not the least, what are the poisons which can cause meiosis versus the ones that can cause mydriasis? This is one of the most important slides again. So the last two slides that I've put, as I said, if you ask me what do I do about toxicology one night before the exam, this is what you need to revise. So the ones which cause meiosis are barbiturates, carbolic acid, nicotine, organophosphorus, and parasympathetic mimetics. You can easily remember barbiturates, OP and parasympathetic mimetics go together, and clonidine, methyl dopa, carbolic acid are something which you can also remember. Under mydriasis, I want you to remember alcohol. However, if a patient comes with an alcoholic coma, the pupil will be constricted there. Please remember that. Apart from that, you can remember carbon monoxide. You can remember datura, which is atropine. And you can easily remember it. Right? Atropine is an anticholinergic, so it will lead to mydriasis. Cocaine is a sympathetic stimulator. It will lead to mydriasis. Carbon monoxide is a stress inducer asphyxiant, so it lead to a sympathetic overcharge, so that lead to mydriasis. Alcohols and amphetamines. Hippus, very specific to alcohol, so very specific to aconite, also may be found in alcohol or barbiturate poisoning. Hippus, as I said, is alternate contraction and dilatation of the pupils. Nystagmus is something which I want you to remember for phencyclidine, for barbiturates, for alcohol. Pinpoint pupils and reduced respiratory rate. Anytime there's depression of respiratory rate, you should always think of opioids or organophosphorus. Cyanosis, it can be any CNS depressant, like cyanide for that matter. Pinpoint pupils, as I said, with reduced respiratory rate is IV opioids. And as I said, any patient coming to you with opioid toxicity, the drug of choice in the emergency is naloxone, IV naloxone. However, the drug of choice for maintenance therapy is oral naltrexone. Dilated pupils and tachycardia is something that you find with tricyclic antidepressants. You can also find associated hypertension with it. You can find wide QRS complexes with it. And the drug of choice for TCA poisoning is usually IV sodium bicarbonate. That's something which I want you to know. So TCA poisoning can come with dilated pupils, tachycardia, hypertension, as I said, and wide QRS complexes. And the treatment of choice is IV sodium bicarbonate. Apart from this, you have amphetamines, ecstasy, cocaine, which can also lead to tachycardia. Anytime in the question you are finding tachycardia, mydriasis, and hypertension, always think of sympathetic poisons. Sympathetic poisons like TCS, sympathetic poisons like amphetamines or cocaine. So that is something which sums up my thing on the you know on the clinical features. A few other antidotes which I found relevant enough, which have been asked: hypertensive crisis due to cocaine, labetalol. Paracetamol poisoning, I'll prefer you writing methionine or N-acetylcysteine, which is used. Methemoglobinemia is methylene blue. Naloxone, as you can see, is found in narcotics. Naltrexone is also found in narcotics. Copper has this antidote called penicillamine, which I want you to remember. It's extremely important. Pralidoxime is something which you use for the nicotinic side effects of organophosphorus poisoning. Physostigmine is something that you use for the datura poisoning, because it is a typical anticholinergic. I mean, it's typical atropine poisoning that you get. So you need physostigmine, which is a cholinergic drug. For heparin, you have protamine, which is the antidote. Thallium, I want you to remember, thallium is extremely important, not yet been asked, but I can expect this question. Thallium is Prussian blue. Please remember copper. Don't ever confuse copper with thallium, because copper sulfate is something which has a Prussian blue color. So never confuse these two things together. Copper is penicillamine. Zinc is also penicillamine. However, thallium is Prussian blue. Just because copper sulfate is Prussian blue color, please don't mark copper with Prussian blue. Vitamin B6 or pyridoxine is something which is used in isoniazide toxicity, which is why any anti-tubercular drug regimen, after they give isoniazide, they'll always add a vitamin B6 along with it. Cyanide is hydroxycobalamin or sodium nitrite or sodium thiosulfate. And this combination of sodium nitrite, sodium thiosulfate, and hydroxycobalamin for cyanide poisoning is what we typically call as the Lilly's kit, Lily''S, Lilly's kit. Lilly's kit is something which is comprising of sodium nitrite, sodium nitroprusside, and sodium nitrite, sodium thiosulfate, and hydroxycobalamin. And all of these three drugs are the part of Lilly's kit, which are used in cyanide toxicity. Warfarin toxicity is treated by vitamin K. Coming to hyperthermia and hypothermia. Hyperthermia and hypothermia are two environmental emergencies which I wanted to talk of. Hypothermia is caused by drugs like by features like serotonin syndrome, where there is agitation, where there is severe sweating, there's tachycardia. So anytime there's tachycardia, sweating, hyper reflexes, exaggerated reflexes, hypertension, should always make you think of poisons which are sympathetic overdrive poisons or serotonergic poisons. Hyperthermia in case of serotonin syndrome is due to the increased flushing that you find. Also, it can be found in neuroleptic malignant syndrome, which can happen, following the post anesthetic complications which can happen as neuroleptic malignant syndrome. It can also be found in aspirin poisoning, which can again mimic tachycardia, metabolic acidosis, hyperventilation, and amphetamine poisoning. Hypertension, I told you already, cocaine, MAO inhibitors, tricyclic antidepressants, all of them come with hypertension. Seizures are a very common side effect of TCAs, anticonvulsants, NSAIDs, phenols, isoniazides. So these were the basic summary that I could give, except for the last slide, which is there for increase for this one. This is the one slide which you can ignore if you're going for for your entrances. But till this slide, everything, trust me, everything till this slide is very, very, very important. I've still told you the ones which are extremely important, and you can just keep solving your previous year questions. You'll find a lot of help from these slides that I've given you, and all of them are consolidated at one place, which will make it very easy for you. Thanking you all for this for joining this webinar. I'll be sharing my video right now, and I hope you can see me. And I'd like Gagana to take over. I would encourage questions which are coming. I do find a lot of a question has come up. This is Dr. Yogesh, management of overdose of LSD drug. Okay, LSD drugs initially they do not have any specific antidote. They are managed symptomatically. We give IV haloperidol for the for the psychotic features which are coming in, and the rest, if there's any respiratory paralysis or cardiac arrhythmias which are developing, we treat them based on the symptomatic management. I'd love to encourage questions and then ask Gagana to take over. Thank you, Dr. Akhil. Dr. Pratibha, thank you so much. Dr. Krishna, thank you. Thank you so much. Thank you. Thank you so much. I've been receiving a few appreciation feedbacks, and trust me, it means a lot to me. Thank you so much for joining. Thank you so much for being there. Thank you, Dr. Yogesh. This means a lot. Please take a look through the PDFs. I prefer you seeing them by tonight itself, so that the visual memory and my audio and what you see in the PDFs is something which you can relate to. I want you all to take a very quick look at the PDF, and I want you all to see the last few slides which I've added, where I've tried comprising everything of the poisons that are relevant for the entrances which are asked. I've kept this discussion very entrance specific because I know it's a topic which which is a very entrance specific topic. Thank you so much, Dr. Ravina. Thank you so much, Dr. Mujassim. I'm thankful to all the ones who have joined. And Gagana, am I audible? I'll be still reading your questions. If there's anything that you want to share, I'm all yours. Is there anything that you want to talk to me about? I'm right here.
Oh, okay. You were not. Yes, doctor.
Yeah. So as I said, I was having a talk with a few students. I've completed my presentation. I would want you to take over, and I'm still open to receiving any questions, if at all.
Sure. Just give me a moment.
Thank you, Dr. Parmart. To all the thank yous that are pouring in for the appreciations, it really means a lot. Thank you so much. I'm open to hearing you out for any questions that you have on anything. If there's
Sure.
anything that you want to ask me, I'm there for it. At least the next 5-7 minutes on any topic. If you wish to ask me, there's something that you want to share with me. There's something that you want to where you feel my insight might help you. I'm ready to have a talk with all of you.
Thanks, doctor. Before we conclude, we would like to open the floor for any questions you might have. Please feel free to type your questions in the chat and we'll do our best to answer them. Kindly drop your questions in the chat box.
Yes, Dr. Paramath, you have texted me. Can I ask? Yes, you can surely ask. Please. Everyone's free to ask me any question that you feel like, which may be relevant to this topic or anything based on medicine. Anything if you just want to share, want to ask. I hope you all are doing well. I hope your families are doing well. If there's anything where you feel I can reach out to you, maybe talk to you, and maybe try giving my insights. I'll be more than happy to. Yes, you are a foreign medical graduate. Okay. Hi, Dr. Parmat. This should help you. This very PDF should help you extremely. I can tell you this: if you're preparing for the FMGs or for the Indian entrances like NEET, this should be something which should help you out. Are you eligible for this course? For this course, I mean, which course are you talking of, Dr. Parmat? I did not get you. These are free webinars.
No, I think he is asking for the Mediversal courses.
Mediversal courses, yeah, you're eligible. Of course, you're eligible. Why won't you be eligible? Everyone is eligible. I don't think there's any problem, Gagana, with foreign medical graduates taking up Mediversal courses.
No, there's no problem, but they must have cleared FMG exam.
Okay, they should clear FMG exam, or they should. Is it just sufficient that they have an MBBS degree with them?
They should clear the FMG exam.
Okay, they
For
should
additional
clear.
information, kindly please contact the number which I have given. We'll give you the complete
Okay,
details on
perfect,
this number.
perfect. So, Dr. Parmat, that's the maximum that I can help you. So yeah, as I read, you don't have an Indian medical registration. You should, I think, ideally, that's the only way that you can be a part of these courses is you have to clear your FMG exam, and that is how we can get the Indian license. And post that, we can always, we
Actually,
can always.
we have different type of courses. It depends on the courses which you opt.
Okay,
Kindly reach out to the number which I have posted in the chat box. It will be helpful for
perfect,
you as
perfect,
well
perfect,
as me.
perfect, Dr. Parmat. I think Gagana and her team are going to help you with this.
Yes,
Anyone
Dr.
else?
Yogesh will be dropping the certificate link once we complete with the Q&A
I'm so
sessions.
surprised you all have nothing to ask me.
I'm just
No, it's not just about the topic as in itself. I mean, we all are in this profession where doubts are something which are eternal, I believe. There's,
yeah.
there's not a single day when I'm not having a doubt about anything. Which is why I'm like, I always want to be as interactive as possible with kids, because I want them to speak up if there's anything that they're facing from the medical end. If there's anything which I can help, which I can do, I'm more than glad to be there. For certificate links and everything, I think Kagana is going to help, and the team is going to help.
Yeah,
I'm
definitely.
a
We'll
very
remove
I'm
the
a
link.
very technically challenged person. So with respect to this, I can tell you this. I'm still a little bit sound medically, but horrible technically. So the technical end is taken care of by the people there.
Very good.
Thank you to all the ones who have joined. I'm extremely glad to have all of you, and I would love to see more of you coming. I'd love to have more of your friends, more of your colleagues, more of your juniors coming in, and I'll try making sessions as short, crisp, and short, crisp, and mm, as fluent as I can. And I hope the pace, I hope the content is something which you will enjoy. And trust me, I can promise you this, something which will be medically very relevant to you when you are preparing for your entrances. It's something which will help you a lot. So in case the questions are done or anything, I believe there's nothing which is going to be there. Gagana, you can post the links, and I think we can mutually wish each other a very good night. And I hope you are all doing well, and I hope you
Uh,
continue to do well.
yeah, then let's wait for some time. Like,
Okay,
I think
okay,
there might be some questions coming up. So,
okay.
also, I have some questions from our internal team. Like, I'll wait for a few minutes. If not, I have some questions so that I'll just take up
Yes,
this.
perfect. Also, I would want you all to write the feedback form, because your feedbacks are extremely important to me. Gagan, I'd also request you to share whatever feedback which they are giving to
Definitely,
me.
definitely,
So I would love to know the areas where I can improve, or maybe make things a little better for them.
definitely. Sure, Doctor. I have some questions from our internal team, our
Sure.
existing student questions. I'll be asking in a while for the same.
Yeah, sure. Please.
There is one question from Dr. Aishwarya. That
Yeah,
is, what are the common routes of toxin exposure, inhalation, indigestion, dermal contact? Is what she has asked.
yeah. So, as I said, if we are talking of plant irritants or plant toxins, then it's mainly what happens is people say who are on camping or on hikes, or they have gone for trekkings, or they've gone through forest trips. So they look at a flower or a fruit which looks beautiful, with everything that looks beautiful may not be edible, and they try tasting it. And that's one route of exposure, an accidental exposure. Second is if someone is deliberately using something in order to cause homicide or to kill people, that is the usage of, say, things like thallium, things like datura, which are used as criminal offenses, or to kill people. Like thallium has got an excellent property because it is basically odorless. It will not have any taste. uh, Things like aconite, which where the root is poisonous, it is sweet. So basically, it can be mixed with any porridge or custard and can be fed to you, and you will basically not be alive after 2 to 3 hours. And the worst part is it will not be even caught in an autopsy report. So these can be the other ways. One is accidental, one is homicidal. The other things like arsenic, like mercury, mercury, mainly mercury, I told you, it's industrial exposure. Lead can be industrial exposure. Inhalation of fumes can be there. Arsenic can be mainly through most cases of arsenic toxicity, which I have been seeing of late, are because of polluted water resources. And I cannot stress the point about how important basic drinking water is. If you do a test of maximum areas in this country which are near the river banks. I'm not naming cities for obvious reasons, but you can check the arsenic level in water. It is unbelievable. I can tell you of one place where I stayed for quite a long period of time. It was loaded with arsenic, and I can tell you half of the hair that I've lost is attributed to that. People think it's because of the stress of my MBBS and my further courses. It's not. It's a lot happened because of that. Because post me leaving from that place, my stress levels increased at work, but I maintained my hair volume. Uh, so kudos to the excess arsenic that I was getting exposed to, excess iron at times that I was getting exposed to. So most of the times it is on occupational levels, on ingestion levels. You can times have accidental exposure. So mainly whatever poisonings we get in hospital settings, apart from snake bites or accidental exposure, are usually occupational exposures, which is why every under the Indian Factories Act, under the Government of India protocols, every factory has to screen its employees every 6 months, usually, or annually, or maybe even sooner, based on what that poison is that they're screening. For example, lead factories which are building paints have their employees checked every 3 months for seeing symptoms and seeing if they have been exposed to the toxic effects of lead. So a good screening program, good sanitation is something which can really help. uh, when it comes to snakes and other irritants, it's something like you can't prevent snakes from biting you, but you can be careful, and that's the only thing which can do. The occupational exposure, however, should be reduced through screening, proper health camps, proper medical facilities of screening inside the factories. And I think the government is doing all of that. That's a good part.
Thank you, sir. Thank you, doctor. Thank you for answering the question. That's all the question I have from my end from our team.
Thank you.
So I think so. There's no questions in the chat box. So I think I can call it for the day. We can call it for
Yes,
the
I think we can call it a day.
yeah.
And thank you to all who have joined. And I would love to have all of you, and even more of you, and even more of you in my upcoming sessions. So spread it to your friends. I wish I can make them more
Thank,
interesting for you, and we can be this in this together. Thank you. Thank you
thank
so much.
thank you, doctor. Thank you all for joining us today. We hope you found this webinar informative and valuable. If you have any further questions, So, like more information, please feel free to reach out to us. I've already dropped a number in the chat box. Kindly reach out to us to that number. Additionally, I've already dropped a link in the chat box for you to fill out and submit to receive your certificates of participation. Kindly give us your valuable feedback. Your feedback is valuable for us. And also, I have dropped a link in the chat box to follow our social media handles to stay updated regarding our future webinars. Don't forget to follow us on social media for updates on future webinars and events. Have a great evening.
Good night.
Sure. Thank you, Doctor. Thank you so
Thank
much.
you.